when we think about therapeutics, there have been some big questions in the field, and thinking about polycythemia and thrombocytosis, or ET, there was a large trial that has been accrued and is running, asking the question about, for a high-risk patient without previous therapy, what about interferon versus hydroxyurea, which tends to be the standard? What's the real benefit? And I think it's too early to say. At ASH 2016, through the MPN consortium, we saw a presentation of this important study that is showing pretty equal results with regards to hematologic response and bone marrow and molecular response. The thinking is we probably need to wait a little longer to see that data mature to really assess it fully. And as well at ASH 2016, with regards to myelofibrosis, we've had ruxolitinib approved now for many years and been looking for competition. Can there be a different JAK inhibitor that may offset some of the anemia that we see with ruxolitinib? What about patients with low platelets? They're hard to treat. And there's some updated data from studies of pacritinib, which is a JAK inhibitor with probably the ability to be useful in patients with low platelets. And that was a late-breaking abstract at ASH 2016 and showed, I think, very good data. Not presented at ASH, but in the background is updated data on momelotinib, another JAK inhibitor with probably the ability to offset anemia. And some of its trials showed that it can really hold its ground and offer some of the similar benefits as ruxolitinib, but not perhaps as complete as we thought. But I think we're going to soon have alternative JAK inhibitors that allow us to treat patients with more difficult blood count imbalances, if you will.